In relapsed and refractory setting, I would select an immunomodulatory drug-based combination when patients have been previously exposed to proteasome inhibitor-based combination and they have not previously received lenalidomide as maintenance after transplant or lenalidomide and dexamethasone as continuous therapy as part of the first line of therapy. In this situation, IMiDs, lenalidomide and dexamethasone would be the backbone to which we have to add a third drug, carfilzomib, ixazomib, ilotuzumab, or daratumumab. However, for patients in which the first line of therapy included immunomodulatory drugs, lenalidomide as continuous therapy or lenalidomide after transplant as part of the maintenance, for these patients, proteasome inhibitors would be the backbone to choose at the moment of relapse. The approach for slow versus rapid progression is different in the real life because when we have in front of us a patient with a rapid relapse, this is usually equivalent to a very aggressive relapse with a high monoclonal component, with anemia, renal impairment, sometimes even with extramedullary disease. In these patients, what we want is to control the disease as soon as possible. And in this situation, we have to choose the optimal combination, a combination usually based on a proteasome inhibitor, an immunomodulatory drug, and dexamethasone, because these combinations based on PIs and IMiD have demonstrated to rapidly control the disease, and this is what we want. By contrast, for slow relapses, so we can probably choose another options of therapy, including the monoclonal antibody like ilotuzumab, but the rapid control of the disease is not so important as in patients with rapid relapses.
What is my personal approach for patients with aggressive relapse and those with biochemical relapse? Aggressively relapsed needs to be forcefully treated. Triple combination, if possible, plus an antibody. So again, proteasome inhibitor, IMiD, dexamethasone, and if possible, an antibody. Slowly progressing relapse, biochemical relapse, is something which has to be discussed with the patient because there's no indication that starting treatment early improves this survival. So, and many patients want to maintain their daily life without the, let's say, burden of treatment. And you can do this if you can follow them carefully. But you have to have all the means at hand which are needed to, let's say, monitor his disease. You should have a skeletal survey with modern technology from time to time. You have to have the free light chains. You have to look at all other and many other parameters and his well-being. And if there are signs for progression, then you would argue to your patient that the time has come to start treatment. What you want to prevent is scrap criteria, namely progression of bone disease, renal impairment, of course, hypercalcemia, that is clear, and anemia, that is easy because and that is probably the most frequent indication for starting therapy in those patients is increasing anemia. So if the hemoglobin falls by 2 grams, then it may be the right time to discuss with your patient restarting therapy.
Patients not candidate to autologous stem cell transplantation usually received in the first line of therapy when they are newly diagnosed a bortezomib-based combination during a fixed therapy of approximately 1 year or continuous treatment with lenalidomide and dexamethasone. If the first line of therapy is a bortezomib-based combination during a fixed duration, at the moment of relapse, one possibility is to use lenalidomide and dexamethasone as backbone plus a third drug. And if the patient was sensitive to bortezomib, we can choose again a proteasome inhibitor like carfilzomib or ixazomib to be combined with lenalidomide and dexamethasone. And as we are talking about elderly patients in which the convenience and the tolerability is a key aspect, ixazomib in combination with lenalidomide and dexamethasone is an excellent option. By contrast, if the patient, non-transplant candidate, is coming from continuous therapy with lenalidomide and dexamethasone, the optimal choice at the moment of relapse would be a proteasome inhibitor backbone. So probably the patient would be candidate to receive bortezomib plus dexamethasone plus something else, or carfilzomib plus dexamethasone, or ixazomib plus dexamethasone, but what we would not do is to repeat again treatment with lenalidomide and dexamethasone.
In the transplant ineligible patients, the overall approach to treatment of relapsed myeloma is going to be fairly similar to what we use in the transplant eligible patient population. Obviously, patients who are transplant eligible, now we are talking about older patients, more frail patients, and patients for whom coming back to the hospital on a regular basis can sometimes be challenging. So there are some modifications we need to make to our approach in patients who are transplant ineligible, who often also have comorbidities. So these patients are more likely to have underlying hypertension, cardiac disease, and diabetes and other common ailments that we see in the older patients. So the type of agents and the dosing that we use in these patients has to take into account the underlying comorbidities. So in somebody with diabetes, we certainly want to scale back on the use of steroid medications. Somebody with underlying cardiac dysfunction, we have to be more cognizant about drugs that may have cardiac toxicity, and especially the use of significant amount of fluids in these patients can be challenging. We know patients who have underlying respiratory conditions, we know reactions to some of the monoclonal antibodies can be challenging, and these patients need to be watched very closely and may even need to get their first dose in a more supervised setting, because we know that these allergic reactions don't carry over to the subsequent dosing in the majority of these antibodies. So we certainly need to customize the therapy for the patient. I don't think a given drug is an absolutely contraindicated in any given setting. Obviously, somebody with significant heart failure, we don't want to use a drug that has a risk of heart failure. But majority of the drugs that we use in myeloma, we can modify the dose in a fashion that it does not increase the toxicity.
So what is available for patients for relapse treatment if transplant is not a choice? And transplant is a choice only for younger patients who have stem cells stored or where you can collect stem cells. So the majority of patients need a non-transplant regimen. And as mentioned, nowadays there are 29 different regimens which are recommended by the NCCN for use in patients with relapsed refractory disease. But you probably will use those who are those regimens which have been proven to be highly active and well tolerated. So there are a few, and of course ixazomib lendex is one. You can use carfilzomib dex, you can use elotuzumab lendex, so of course daratumumab plus lendex would be an ideal choice again. So these are the major players you consider first, but if they have been used before and patients are relapsing on these or after these major players, you have to look for other drugs, and you would think about pomalidomide, you would think about panupinostat in some cases, and you would think about when it comes to, let's say, 5th, 6th or 7th relapse, then probably you are left with very little in your pockets, but you still can use what has been developed by Bart Balogi, is DSEP, which is continuous therapy 4 days, or VTPase or so. That helps a little in many patients, but the results or the remissions are not very long lasting. So finally, you may end up with very good supportive care.
In patients with relapsed myeloma, we have the option of using many of these triplets that have been studied in the phase 3 trials. So in a given patient, whether we use a monoclonal antibody-based combination or a proteasome inhibitor-based combination with the immunomodulatory drug depends a lot on the patient characteristics, the disease characteristics, as well as the logistics that is involved with administering the therapy. So in a patient who has previously seen a proteasome inhibitor or who is currently relapsing on a proteasome inhibitor, my choice would be to use a monoclonal antibody-based therapy. So let's say someone is had initial treatment with a bortezomib, lenalidomide, dexamethasone, had transplant, and was staying on a bortezomib maintenance. If when at relapse, I would use a combination like daratumumab, lenalidomide, dexamethasone. Suppose the same patient was on lenalidomide maintenance and now is relapsing on lenalidomide maintenance, I would consider using a combination of a monoclonal antibody with a proteasome inhibitor, like daratumumab, bortezomib, dexamethasone would be a good combination. Now, let's say somebody is an older patient or a patient who does not want to come to the clinic every week to get an infusion, then I would think about using an all-oral combination like enoxaparin, lenalidomide, dexamethasone. Now, if a patient is has previously seen a monoclonal antibody-based therapy, for example, let's take a patient who had a bortezomib, lenalidomide, dexamethasone induction transplant and was on lenalidomide maintenance. They relapsed. They were treated with a monoclonal antibody-based therapy as a second line of treatment, and now they are relapsing. I would consider using a proteasome inhibitor-based combination and possibly combining that with maybe pomalidomide in that particular setting. So I think the three main characteristics we need to take into account: the effectiveness of the prior therapy with a particular class and the toxicity that they have seen, the high risk characteristics of disease relapse, and finally the logistics of how often they can come in and get therapy. Key message when you consider treatment for relapsed myeloma is to try and include at least a class of drug that is different than what was being used in the previous line of therapy. Again, keeping the principle of using at least 2 different classes of drugs in a given combination. So switching the class as well as switching drugs within the same class is critical when you decide on new therapies. So if somebody is refractory to lenalidomide, coming into making a decision on the optimal regimen, I would use a combination of a monoclonal antibody and a proteasome inhibitor if I can. If I have to use a immunomodulatory drug, then I would certainly move on to a pomalidomide in that setting, again in combination with a monoclonal antibody or a proteasome inhibitor.
When do we consider a proteasome inhibitor backbone as compared to an IMiD inhibitor? I think this is important, particularly in patients with high-risk cytogenetics, where we have shown, or where people have shown, clearly shown that proteasome inhibitors overcome at least to some part the negative impact of high-risk cytogenetics. So a proteasome inhibitor is very important here. But you may combine it with an IMiD as well. If you want IMiD combination only, I think I would focus on standard risk patients without high-risk cytogenetics. But sometimes you don't have too much choices, particularly after many relapses. So then you go with a pomalidomide dex regimen, which is very good, seems to be very active in patients with high-risk cytogenetics, particularly deletion 17p. And you may add then something else to this combination like cyclophosphamide or even an antibody. So you have a lot of choices. And I understand our desire for a simple algorithm, but my answer to this question is that will not be possible in the near future, given this plethora of options and the differences in patient characteristic and the biology of the tumor in individual patients. So maybe in very far future that will be easier.
Patients with myeloma can relapse with very different tempo of the disease. The vast majority of the patients who relapse, the same principles hold true for treatment of relapse. I think what we have learned from the recent clinical trials is we should certainly consider using triplet combinations. We should use combinations with classes of drugs that are non-overlapping compared to the prior line of therapy. Certainly there is a subgroup of patients with very indolent and very slow relapse where we may be able to hold off on therapy for some period of time. But what is more important to tease out or characterize separately are this small group of patients who present with very aggressive disease. And these are the patients who present with rapidly increasing monoclonal protein, patients who present with extramedullary disease, and the patients who may present with secondary plasma cell leukemia. Now these patients have to be treated fairly aggressively, and these are patients where we might try and use some of the older, more conventional chemotherapy type medications, at least for the initial control of the disease. So many of us would use combinations like VDT-PACE or combinations that include high-dose alkylators and anthracycline to try and gain an initial control of the disease, with the understanding that we will follow that up with something which is less intense, which incorporates some of the newer drugs.